It's great to see y'all. I see some new faces here with us today, and I welcome you today to the final meeting of the Study Committee on Children's Mental Health. It's good to see you. We have had a great conversation with some just wonderful information and challenging thoughts to see what we can possibly do to make this better for Georgia's children. I'm going to ask, first of all, I'll introduce myself, and then I'm going to ask the committee to introduce ourselves, and then I'll introduce our two guests that are also with us today. So Katie Dempsey, I'm from Rome, Georgia. I'm privileged to be chairing this committee. It is, like I said, just been very powerful to listen and to try to embrace some of the things that many of you deal with every day among people you love and care about, and among people that you work with, and all that we want to have the best opportunity to be the best person and lead the best fulfilling life that they possibly can. So if I could start on the end with Pat, if you would introduce yourself to the room, please.
Thank you very much, Madam Chairman. I am Representative Pat Gardner, and I represent the City of Atlanta, heart and soul of Atlanta.
Representative Jaspers.
I'm Rick Jaspers. I'm in House District 11 up in beautiful Jasper, Georgia, 2.5 hours away from here at this time of the morning. And yeah, this has been an interesting committee. You never think in the legislature, especially on study committees and bills and stuff, you never know why you're put on things. But it's just interesting. Like this morning, I'm talking to my daughter. She's a high school teacher in Warner Robins, teaches AP English and regular English, and this very subject came up in our conversation, and mental health and some of her kids, and so it's just very timely for me. And thank you, Madam Chairman, for letting me on this committee.
Well, and excuse me, I didn't mean to jump over. I don't know why I did that, except that it's still early and wet out, right? Representative Nix.
Yes, I'm Representative Randy Nix. I'm House District 69, which is Troop Herd in Carroll counties, and I'm glad to be on this committee. I had to apologize. It seemed like every time there's been something scheduled, I've had something else, but I'm glad to be on it. It is an issue that I think we need to address in a better way, so thank you.
I'm Joyce Chandler. I represent parts of Lawrenceville and Grayson, and it has really been a joy to be on this committee. I've enjoyed getting to know many of you, hearing from you. I've learned a lot about a very important issue.
And I'm pleased to say that today we are joined by Representative Mary Margaret Oliver and our newly not only elected but sworn in now, Representative Betty Price, who were in the audience, and we invited them to come up and sit with us for sure, because there will be some issues about this in the future. And Mary Margaret certainly has a huge breadth of experience and has helped me very much in dealing with many of these issues. And Dr. Price, I also know, will be a huge asset to our body. Also, Roma Amin, who many of you have talked to, she is my right hand. I know she's sitting on that side, but she is my right hand and makes sure that I am on task with everything we do. So I'm so grateful that she has chaired this committee and helped put together some very meaningful dialogue for us. So here we are. This is our final meeting. That doesn't mean that the conversation ends here for sure. We'll talk about that a little bit more at the end. But we're going to start off this morning with testimony from Gerald Clark. He is a pediatrician with the Georgia chapter of American Academy of Pediatricians. Dr. Clark, and if you are more comfortable sitting, and Rick, will you come up too, if you are, Rick Warren, wherever y'all would like to be. Great. Well, just take a deep breath and know that we're all learning, and you probably know what we need to know. So,
if I might, Madam Chairman and members of the committee and guests, Dr. Clark is vice chair of the Georgia AAP Task Force on Mental Health, and while he's a general pediatrician, I think you'll hear shortly from him about why this is a particular interest for general pediatricians and the issues that we face in trying to improve care for children. So, Dr. Clark.
Let me begin by the prevalence of this condition. And by the way, when we say children, I'm going to assume we mean both children and adolescents, and I'll use the term in that context. Behavioral and mental health problems are increasingly common in today's children, and pediatricians are identifying children with emotional and behavioral disorders at an increasing rate. 1 in 5 children, about 14 million nationwide, have a diagnosable mental health disorder that interferes with their daily functioning. Of those that seek treatment, only 1 in 5 receive specialty services. Thus, approximately 80% fail to receive the specialty services, and many receive no services at all. Lack of access to specialty care, affordability, and financial constraints. Many mental health specialists do not accept insurance, much less Medicaid insurance. Stark shortages of child mental health professionals and stigma related to mental health care are key problems we face in improving the care of children. It is also important to note that the care of mental health disorders for pediatric and adolescent patients differs from traditional adult mental health treatment and necessitates family-focused treatments for therapy for pediatric mental illness, and yet family-focused treatments are not often covered by insurance plans. Because of the problems with access and affordability, general pediatricians are being called to provide care and mental health services for which we, one, often have inadequate training. Most pediatricians are adept at treating ADHD, for which evidence supports medication as an effective therapy. More pediatricians are becoming comfortable treating anxiety and depression, especially in adolescents. But behavioral therapies are an important addition, especially in young children, and often we do not have this resource to give to our patients. For disruptive behavioral problems, specialists in medication, that is psychiatrists, and therapists are often needed. Few pediatricians are comfortable in treating these disorders, but often are asked to help, especially in the foster care system. The second problem is lack of support. By that I mean psychiatrists to whom we can refer and to whom we can even ask questions, and evidence-based therapies and therapists. We're often as unaware of the quality of counselors and psychologists as are our patients. A special care problem is the foster care system, and sort of a quote from a pediatrician in Georgia: foster care is huge. The statistics on percentage of foster kids on multiple antipsychotic and antidepressive medications is staggering. This makes it especially difficult when they are transferred to a new group home in our area without medical records and want us, as a pediatrician, to refill high doses of off-label medications until they get to the psychiatrist. And then personally, as a pediatrician, I wonder, why are these problems so prevalent today? What prevention can be done? So here are some of the suggestions we would have for the committee. 1, we need more child and adolescent psychiatrists and psychologists. Currently, there are only 5 child psychiatrists trained each year in Georgia, which is woefully inadequate to meet the demand. These doctors also need incentives to stay in Georgia so we don't lose them to other states where the practice environments are better. 2, we need the support of psychiatrists as pediatricians quickly when we are asked to provide care for which we do not have the expertise. A few states have provided a hot or warm line that a primary care pediatrician could call to talk with a child psychiatrist for advice quickly in such situations. We also need additional training, and the Georgia AAP is stepping up to address this need. In cooperation with the Georgia Council of Child and Adolescent Psychiatrists, we have held 3 educational programs this year on mental health topics. These were well attended by pediatricians and greatly appreciated. More are planned for the future. 4, we need evidence-based behavioral therapy programs to refer our patients and families to. These are essentially parenting programs, but one with proven and evidence that they work. 5, we need better coordination between the many agencies that have purview over our children in this state. Obviously, the Department of Behavioral Health, Juvenile Justice, Medicaid, foster care, and other agencies have children in their systems with mental health problems. We believe it is the time is right for someone to take a comprehensive look at the mental health services in our state, and with the authority to make recommended changes that would improve communications, make access to the system easier, and administratively less burdensome for providers. Perhaps such an omnibus task force charged with this mission could be helpful in focusing resources and system measures that would improve care for children. Finally, again, I want to go back to my passion, which is prevention. There are evidence-based programs that work. Some can be provided in group sessions that would make them more affordable. Wouldn't it be great if county mental health centers could provide these services? Schools could provide this training for parents. Foster care parents were trained before they were assigned a child with behavioral issues. From experience, I have seen this happen where a foster parent gets a child with behavioral problems that are difficult to manage, and these are wonderful families, and they end up giving up the child because they don't have the support. It's a tragedy for all involved. Madam Chairman, that concludes my testimony. Thank you for inviting us here today to speak on this matter. I'd be happy to take questions if there are any.
Yes. Okay. Members of the committee, are there any questions or comments? Representative Jaspers.
Yes, sir. Thank you, Dr. Clark, for y'all being here. You know, early on, you just asked, you were talking about there were, 5 child psychologists trained a year, but you made the statement psychiatrist, okay, the better practice environment. What do you mean by that? I'm just curious. So early on, you were describing them. You said something about being a better.
In many of the child psychiatrists, there are few trained in Georgia, and the problem is that many leave the state. Of the few child psychiatrists in the programs that are here, many leave. You would probably have to ask the child psychiatrists themselves why they don't stay.
Okay, we just said that. I didn't know if it was something we were doing, or is it, I like Georgia, you know. Yeah, I like Georgia.
And, some of them are, I'm sort of a liaison. I'm learning this with the child psychiatrists. And they also look, what can we do to keep our residents here? Are there programs like maybe establishing one in Macon where they really have a push to keep their trained their trainees in the state here? Would that work better? But why do they have better opportunities, elsewhere? Is why they leave. And what can we do to keep them here?
Okay. Thank you, Madam Chairman.
Thank you. Yes.
Thank you. A little bit of a follow-on to that question. Is there a model state program somewhere where they seem to have put a lot of these pieces together that works?
That's I'm just beginning to learn this. This is a sort of an interest for me, and I'm looking at what other states do. What I've seen so far is Massachusetts has a program where they have divided the state into centers where pediatricians and primary providers can call and get support in getting children into the system. But it's suffering there too, the last thing I read, because of funding issues. Funding issues always come up sometimes. New York has developed some programs for training pediatricians to better manage these issues. What I don't see, and even in Massachusetts, is again going back to prevention. And what can I do to help families when I see they're struggling with their 2 or 3 year old to maybe help them not have a child that with more severe problems at an adolescent. And that's not being addressed well anywhere. But again, what I'm reading is there are programs that really do address that are evidence-based parenting programs. There's a lot that's popular and meets the press, but there's actually some that have evidence that they work.
May I follow up?
Yeah.
In terms of prevention, are you speaking of traits that are mental illness that they were born with these, or how much does environment contribute to these issues?
It's always both, and so the part that we can maybe work on prevention is the environment. There's always a genetic component, some disorders more than others. And again, as a pediatrician, what I can do best is medication, but I know medication is not the answer for most destructive behavioral disorders that cause the most problem. It's behavioral therapies and what can be done earlier, and what can you do to train parents at an earlier age in techniques, because much of parenting wisdom is punishment-based, but that's not the most effective therapy or most effective way to change behavior. Okay, and so again, that's why I go back to from personal experience. We've all parented kids and wonder what could we do a little bit better. I have done a little bit better.
Okay. Thank you.
That helps.
Thank you. Representative Gardner.
Thank you very much, and thank you for being here. I think the education of pediatricians with the array of mental health professionals that we have in our state is going to be really important step forward. Now, there's another study committee that's looking at school-based health clinics, and in terms of your focus on prevention, that seems like a really good place to pick up issues early on and have, I don't know how many pediatricians actually show up in these school-based clinics, but to have access to a pediatrician and maybe a psychologist or some other behavior specialist who can work with a kid instead of sending him home because he's not behaving, to really intervene early and help with prevention. Does that sound like a model that you think would work?
I think a lot of times watching the school system is the default system for many behavioral problems, and they're struggling with these issues too.
Right.
And to have training to handle the more difficult kids, I'm sure everyone in the school system would appreciate, teachers to principals, and whether I think the model of pediatrics is going to change over time because we're going to have to be involved in areas, even for just regular health with the school system. It'll be interesting to see where it goes. But at this point in time, the school system is the default system. But I always look back to even 3 or 4 year olds. Can you, it's that crucial age, what can we do to help parents? Because there are some kids that are just difficult for whatever reason early on.
And maybe if they got some help early on, they could grow up more.
Mm-hmm.
May I ask one other topic?
Yes, please.
So there's another movement with the shortage of child psychiatrists and child psychologists, which is to use the telemedicine model.
Mm-hmm.
And with older kids, it apparently works really well because they're less inhibited on when they can type things in. But would that be helpful for you, or how would you?
They are looking, again, I sort of hear some what the child psychiatrists are doing.
Are they doing that?
And that is the area that they're looking at. Again, there are difficulties with that, like every other area. But telemedicine is something that the child psychiatrists are looking at because, again, getting to a child psychiatrist in Augusta, miles away from where you live
it's very
in
difficult.
Georgia, is logistically hard. So then there's a huge no-show rate, and telemedicine may be an answer. And I think that's being looked at.
So you said you treated Medicaid patients. Mm-hmm. So we have these Amerigroup and Peach State, and do they have the behavior specialists once you find that you need them?
So I'm a general pediatrician, and not all general pediatricians, especially in the northern Atlanta suburbs, take Medicaid. My partner, when I started, said we're always going to take a certain percentage. You do your part.
Thank you.
And
Thank
we
you
also
for that.
gotten on a Amerigroup, and we only take foster children for our parents who want to become foster children. We want to be able to provide that service to them. But it is hard to find services with those groups. I know they're out there, but it's hard for parents to find. It's hard for me to find it with my patients on insurance.
But Amerigroup should do that for you.
Yes, but it takes time. And again, it's a system I think they're working to improve now. It's just Amerigroup, but it's a
takes time, and the kid is in crisis right now, right?
They're in crisis right now.
Well, thank you for being willing to take those Medicaid children.
Thank you, Representative Gardner. Representative Chandler.
Thank you. Going back to your mentioning the better coordination, I serve on another study committee, and Dr. Gary McGibney from DOE, who happens to be here, has presented to us a proposal for what he has called a mental health state strategic plan. I think it would address some of the issues you've mentioned. And if I might, before you leave, I'd like to hand you a copy. I just happen to have one.
I'd love to read it.
Okay.
I'd love to read it.
Thank you. And another question quickly.
Yes.
I know we need to
it's
move
fine.
on. Would you tell me how you see this having better behavioral programs to refer? How do you see this looking?
I tell you, I'm still working on that. Again, I'm just trying to learn what are therapies, behavioral therapies at work, and they're out there, and what those programs are. And I have an article with me that has a table that has some that I can leave with some resources. And I'm trying to learn what those programs are. But if I have a parent who's struggling with their child at an early age, for whatever issues, I'd love to have some program that I could send them to that really teaches parenting skills. And I'd love to have it for different age groups and different difficulties, but again, there are, whether it's run by a county mental health center, or there are some psychologists who are trained in these programs that work, and it's an intensive training for people I've met who've done this. They have to sort of really do follow-up and check and see progress and send reports into sort of their center that's sort of, I'd love to have those resources, and they're very few in Georgia or anywhere. And I'm not sure who should sponsor it, but I would think if schools sponsored it, I love community-based centers to sponsor it. I also was telling Rick I love churches be able to sponsor it. You know, we need a variety of settings that people feel comfortable in.
If I might add to that, one of the things that some of our members talked about when we were preparing Dr. Clark's remarks were maybe county mental health departments where they exist. We know they don't exist all over the state. Perhaps could increase their capacity in children's mental health. Certainly other mental health specialists like licensed professional counselors could be supportive and have a role in this kind of training that Dr. Clark mentions. And I think obviously an investigation of what other states are doing in this regard, because as he mentioned, this is evidence-based information that we know works, and so it seems to me a scan, a nationwide scan to see what other states might be doing this would be prudent.
But again, that goes back to this coordination issue too.
Touche.
Chairman Nix.
Thank you. You're going to be glad I wasn't here at those other meetings. If I had been,
we missed you.
We might have been still in the last of the first meeting if I'd have had these many questions. A little bit of an observation and a question too. I had Ariane Weldon, who's the head of Get Georgia Reading, make a presentation for me. And one of the things that she talks about is language, nutrition, and talking to the things. She told us that they have actually got a program approved now for nurses to get professional credit for learning more about that. So I guess the comment is we need to look at coordinating a lot of these programs and what may be some of those reasons, because she has tremendous statistics on the number of words that a child has by the time they get to preschool and school, and how you project that out, and what a tremendous difference that can make along the way. So I guess my comment is we need to try to coordinate as much of that as we can, and that additional training for the nurses I thought was very interesting, and that they will actually give them credit for learning more about those processes, which would be helpful, I think, to you.
I think so, and it's not necessarily some of the behavioral parents can be trained to do it. There are many options in this. I was reading in this article there are certain populations respond to apps on their phone, and there are things that are out there.
And they're working on an app that actually helps with that at this point in time. So I guess bringing this to light in more and more different settings, I think, is good, because sometimes we think we're working on things in a silo, but there are other people working on it in different ways too. And I appreciate your comments. And I guess it's interesting to know that you feel that frustration as someone who's more trained than we are. So when we see it and have people call us as representatives, and I'm having this problem, I don't feel so bad now that I'm frustrated, since I know that you're frustrated too. So.
Treating patients, seeing family members struggle with these issues is personal and professional. And that's why I'm sort of passionate about it. But again, I too don't know where to go and how to coordinate this.
And thank you,
Okay.
Thank you for that passion too.
Okay.
I really appreciate it.
Thank you.
Well, thank you. I was just going to tell you how much I appreciate your comments, and that we share a lot of that frustration among all of us when we do hear from people, or it touches our own lives. And certainly in the hearings that we've had for this committee, that has come forward and come forward and come forward. And I like you, Representative Chandler, with Gary McGivney sitting in our room, he honors her so by doing that. Dr. McGivney is such a great example, and his passion and concern, he has shared that also with our committee. And I think there's no doubt that we do need, like you say, some structural form that is really coordinating this effort and dealing with that early intervention and prevention model, because the numbers are growing and families are hurting, and children
Correct.
certainly are not reaching their potential because of it. So I thank you for helping us in this. We're going to come out with some things that are better, and there's no doubt, y'all, it's going to take us a little while, but we're going to start working on it together. Each and every one of you here are going to help us. I know that. Thank you.
I thank you.
Thank you. There's nothing better than a pediatrician. I tell you what, if you are a parent, they are in the saint category, because you walk in and present, and it's like make it go away, make it better. So thank you for finding time to be here with us today too. Our next speaker, we have two. Susan Adams, she's the Assistant Commissioner for Pre-K and Instructional Supports, and Jeannie Couture, if I'm saying that wrong, you correct me, Director of Instructional Supports for the Department of Early Care and Learning. Such an important group that really helps us address exactly what we're talking about, that early intervention, prevention, and giving those children everything they need to a good start. Thank you.
Good morning. It was a nice setup. A lot of the things that have already been. Oh, okay. It doesn't matter. I have a copy, so, but if we want to put it up, we can. It doesn't. Do you guys need a copy? Okay. Sure. Perfect. Or whatever's coming. It does either way. I'm happy to do it either way. It's minimized on the desktop. All right. All right. Good morning. As you said, I work with the Department of Early Care and Learning, which most of you know looks at services for children 0 to 5. Dr. Clark set us well to talk about early intervention this morning. But the first thing I wanted to kind of do was just to set the stage to think about what mentally healthy infants and young children look like. Many times as we think about mental health, we don't think about our youngest children. That's not a topic that people think about, but it is something that is crucially important. And so we need to start from a place of what do mentally healthy infants and toddlers look like, and what are the things you should be seeing from them. So, as you think about infants, these are infants that are responsive. They're infants that are responding to the environment and the people around them. They are picking up on cues. They're also infants that are beginning to self-regulate themselves. As you think about toddlers, those are those little children that are beginning to explore their environment. They're beginning to try new tasks. They have strong relationships with caregivers that, in order for them to be able to explore. And then, of course, if we look at our preschoolers, our 3 and 4-year-olds, those are going to be our children that their world is getting bigger and it allows them to have new opportunities to interact with more people, more kids, preschool. And then also they're beginning to really have more self-regulation skills. They also, if they've had a good relationship with an adult, they seek adults for support. And they're beginning to also enjoy learning new things. So as we think about infants and toddlers and young children, we want to kind of start from that place of what should it look like. And how do they have good mental health? Well, they are in environments where they are able to have opportunities to experience, manage, and express a full range of emotions, both positive and negative. They develop close, personal, positive relationships with their caregivers. And they can explore those environments. So one of the things we want to think about is that social emotional development and mental health go hand in hand. In order for children to have good mental health, they have to have good social emotional development. And we also know that if we look at those two things, that they're strongly associated with a young child's ability to be ready in kindergarten. So children have to have good social emotional behavior to be successful in kindergarten and then in school, and or even look at adult outcomes. You can track it back. And it is a fundamental overall piece of the child's overall health. So it's not just about, social emotional, but that also connects to other health outcomes like obesity and those things. And that the early environments and experience and relationships have a lasting impact. So today when I talk to you, I know that a lot of people have talked to you about the gamut of children and mental health. I'm really going to focus on 0 to 5 because what we know and what our agency focuses on is that what happens in those first 5 years sets the path for those children for their whole life. And it can also make a difference to mitigate, some of those things that with mental health that are going to happen. And then early behavioral challenges are predictive of future challenges. So we don't have children that suddenly develop these problems when they enter kindergarten or 3rd grade or when they're in high school. Many times these things started on early. And we're able to identify them early. We've got to get them service early on. So what does it look like to support mentally healthy infants and toddlers and young children? So what do they need? They need responsive caregivers so that they have good attachment to and good relationships. Building positive relationships is the foundation of everything with mental health. They have to have that strong attachment to their caregivers, not just their parent and their guardian, but also are there other primary caregivers? If they're in child care, if they're in a preschool program, or they're cared for by grandparents. They also have to have consistent, predictable schedules. Young children need to be able to understand what's going to happen and what that means for them, because what they're learning is self-regulation, and they're learning to explore their environment. They can't do those things without those predictable routines and environments. And we know that many of our children don't have those things in their lives. So it is causing those environments where they're not able to do that social emotional development. We talked about they need those safe environments, and not just to keep them safe, but so that they can explore and have those things that do affect their brain development. I need to be able, as a toddler, to be able to interact with materials and other people. I need to be able to play. And then the thing that we've talked already a lot today is about early intervention and support for young children. The thing is that many, years ago, we said, you can't identify these things early. You can. There are many red flags that can be identified. We've got to identify them and be able to identify them in ways that connects to funding and resources, and then we've got to build a system where those services are there. A few statistics that are specifically about the population 0 to 5. Anywhere from about 10 to 15% of children between birth and 5 years experience social emotional problems that are negatively impacting their functioning, development, and school readiness. There's research that shows anywhere up to 30% of our children are not entering kindergarten socially and behaviorally ready for instruction. So you can expect children and teachers to teach academic subjects if we don't have children that are ready there with the social and emotional skills they need. The other thing that we know is that early diagnosis and treatment are rare. Less than 1% of young children with emotional problems are identified, and nearly 2 to 3 times more preschool-age children exhibit symptoms of trauma-related impairment. More of them are diagnosed. And then of those that are diagnosed, over 80% of those children, ages 3 to 5, that have been identified, don't receive services. So it's an issue of not only identifying, but then how do you get the services? So we want to put a couple of policy recommendations on the table, and we're going to specifically think about things that look at system level changes, especially for children and families 0 to 5. You need to promote quality child care settings that support social emotional development and the mental health of young children. Our children are being cared for out of homes. Over 80% of our 4-year-olds are served in settings in a child care or pre-K setting out of their home. We need to make sure that we're supporting them. Specifically, we'd ask that you look at supporting the quality rating improvement system, which is the tiered quality rating and improvement system in Georgia for improving child care, and look at supports for funding. Because many of those direct to support child care programs and improving their environments and supporting better recruitment and retention and training for early care teachers. There's also a recommendation that will come to the Education Reform Commission out of the Governor's Reform Commission for Early Childhood that specifically looks at funding to go towards social emotional development training and resources for early learning programs 0 to 5. That's based on a evidence-based intervention model for child care learning programs that looks at positive behavior interventions and supports, which of course we already support in K-12 in Georgia. We also need to look at addressing the lack of trained providers in health, mental health, and early care and education settings, which we've already talked about today. And a lot of people are going to talk to you today about the lack of psychiatrists, but we also want to make sure that our early care and education workforce understand how to support social emotional development. Many of them, that's the area that they feel least able to do that. And so how do we support them? We also need to look at other states that are doing things like mental health consultation for child care programs so that you have people that can be on site supporting programs that have children that they've identified with red flags. We need to support and fund the use of developmentally appropriate screening and assessment for very young children. Right now, many times we have children that may be assessed in their pediatrician's office, which is certainly a good start. But we also know that a pediatrician's time with a young child is short and intermediate. We also intermittent. We need to look at training people that are with children every day to use developmental screening and developmental surveillance so that they can identify what are the red flags. And then, once I've identified that I'm concerned about this child, how do I communicate that to a parent, which is a totally different skill, and then also how do I connect that parent and family to services. We need to ensure that home visiting programs can address the needs of children and families with social and emotional behavior problems. In Georgia, there is a pretty effective, robust home visiting program through our Department of Family and Children Services, but we also need to make sure that family visitors know how to support and identify those red flags. It's also a good opportunity to think about embedding those evidence-based parenting trainings with those home visitors so that when they're in those programs, they know how to work with families on working with their children. And then we also need to make sure that that system is connected with the other things that are going on. Because these are people that are going into homes of our neediest families, children with identified issues, working directly in their home with the families. Then we also need to connect that home visiting program back to the child care program. We need to create mechanisms, including through Medicaid, to support the development and reimbursement for on-site mental health consultation and early care and learning settings. There are many states that are doing this successfully, and Georgia needs to figure that out. There are ways to identify young children and get them services, and we need to make sure that's happening, but we also have to connect that to the places where our children are. And then we also need to explore alternate ways of paying for therapy services for very young children who need sustained professional intervention. Much of what we can do is prevention in 0 to 5. We know that if we can look at identifying and supporting those children and families early, that many times that we can mitigate some of the problems that are going on. But then we also have to address children that need sustained professional intervention, and not only look at where do I find that and how do I get the services, but also how is it paid for. I know I've given you a lot of information, so I'm going to stop there and join Jenny, who is our resident expert at the table, and we'll be happy to answer any questions.
You've given us a lot of very good information. I appreciate it. So questions, or Jenny, did you have any comments at all? Okay, our first one, I believe, is Representative Gardner.
Thank you, Madam Chair. The policy recommendations are very helpful. Thank you for those. Because of the high level of poverty in our state, a lot of the things that you're talking about manifest themselves in really low income communities with children who are probably eligible for Medicaid. Mm-hmm. And we have now, apparently we're going to have 4 providers of care management organizations who have the expertise, we hope, to deal with some of these issues. And one of the things I heard when I visited one of those centers is, we all go out and read thanks to Voices for Children, but it was a Easter Seal Head Start program, I think. And one of the issues was that they had available people who could provide these early intervention services. I mean, we really probably don't want to give these children a diagnosis of serious mental illness at 3 or 5 or whatever, but they may need just a little bit of help or working with the families to figure out how to get back on track. But they can't seem to figure out a way to bill Medicaid or to get the CMO to pay for that service. And what you've said, I think, is very wise about the need for those services to be adequately reimbursed. So we look forward to working with you on how we can make sure that the CMOs, with their new contracts, provide that service, which we all know is really critical. If you have specific ideas, I hope you'll send them to us.
Sure. One of the things that is mental health services for young children, especially infants, is certainly that something that is at the forefront of practice and research right now. There are a lot of recommendations that are coming out of national and federal groups that we'll be happy to share. National groups like 0 to 3, and then also from the federal government, and that have very specific recommendations. We've also connected with the Georgia Reading Campaign and looked at how do we explore some of those things about how do we work through places like AmeriGroup to look at services. Jenny and I will actually be going to a conference that is about infant mental health in a couple of weeks to really look at what other states are doing. Because what we're finding is other states are figuring out ways to connect all of these services.
So you're going to learn how
Yes.
Medicaid can ensure that
we are hopeful that that's what we're going to learn. We're going to look at, there are some other, Florida has a pretty good program out of Florida State University. There are some other states that are doing some interesting things. North Carolina's looking at some promising practices that look around parents. And so we're really trying to figure out who has figured out at least parts of it to bring back here to Georgia.
Have you had any discussions with the care management organizations to determine?
We've had some very preliminary discussions.
Thank you, and thank you for the work you're doing for our children.
Thank you. Representative Gardner. I'm sorry, I punched the wrong button. Representative Chandler, sorry.
Do you know to what extent social and emotional development is part of an early elementary educator's training?
So social emotional development is probably more connected to teachers that are getting a degree that focuses on birth to 5. I think there is some training. I'm by trade with an elementary teacher and came down to pre-K. There is some, but I think that there certainly could be a more emphasis on social emotional development. I think that the Department of Ed has done a really good job in scaling up positive behavior interventions and supports, because I think that not only tells teachers what to expect, but gives them specific strategies to try. One of the projects that we're working on through Get Georgia Reading is a project to look at the K-12 positive behavior intervention support model and look at taking the early education one, which is birth to age 8, and look at how you infuse those two things. Because the other thing that we have to remember is that children don't magically change when they enter the doors of kindergarten. Early childhood is really birth through age 8. And so we have to really honor those developmental things that are going on with our children in early elementary and support teachers in understanding what is developmental. I'm 5, and these are the things I'm figuring out. And then also give them strategies for how you approach that. Because that's very different than if I'm working with a 10 or 11-year-old than working with a younger learner who may be much more concrete. And so I think there are strategies, really good ones through PBIS, some really good things through Get Georgia Reading that are happening. But I do think there has to be an emphasis and think about what goes on in those developmental ages, which really goes up to age 8.
It's positive behavioral interventions and supports, and there is a model specifically for programs who serve children birth to 5. But I was thinking about what you said, and so many of our child care programs are staffed with folks who do not have college degrees. So we have a state leadership team that is looking at implementing some of these practices in our early childhood settings through implementation of the pyramid model, and we are working with the technical college system to embed this into their curriculum that they use to train our early childhood folks. And then because so many of them, like we all are older, and they do in-service training, so we're embedding that into their in-service training, because chances are they may not go back for a higher degree. But we realize that it's been an area that has not had enough focus over the years in education. And as an educator, and a special educator, I did not get a lot of it myself back in the day, as they say. But we're trying to really remedy that.
Thank you. Representative Gardner? Did you punch your button again? No. Okay. Okay. Yes. Are there any other questions or comments? Chairman Jaspers?
Yes, ma'am. Thank y'all. That's a practical question. The rubber meets the road kind. So in pre-K situations, there are a wide variety of them, even in my district. What tools do you provide through DECAL or who to the educators and those that, I think you started mentioning it there toward the end of that last question, how they can effectively deal with it? Do we embed that in their training that they go to in August or when they get started, and because most of theirs is just straight up behavior, as maybe a mental challenge, but they're seeing it as behavior. And what I'm hearing in my area, they're not able to handle it.
Right, and we're kind of hitting it from a lot of different ways, because we know that again, some of our folks are not prepared to deal with the kinds of challenging behaviors that they're seeing in their classrooms. So we're helping them look at some prevention, how their environment works, how their relationships are with the children, what kind of the setup is that helps everybody be successful. And then we're also have a group of people called our inclusion specialists who work for DECAL and who go out and support the teacher. They don't work with young children with challenging behavior, but they support the teacher to make a plan for how they can support that child with challenging behavior. And some of our programs that are working in our pyramid model project this year have really just expressed a lot of surprise and excitement with the fact that the kids that they would have called us about last year, they have put some things in place, and those children, while they may have a bad day every once in a while like we all do, they have really been able to be successful in attacking the challenging behavior through prevention and some intervention. So we are providing those kind of supports with our inclusion program, and then with the training that we do. We have a training that all new teachers get from Georgia Pre-K related to classroom management, and then we're also creating a number of modules for them to do on their own related to more specifics about managing children with challenging behavior.
Madam Chairman,
Yes.
In many, since we're across the state, I know it's a variable, but are many of the pre-Ks have the link, or do you encourage them to have a link to the K-12 school? Because that's where they're going to end up the next year, and of course they have vast resources generally. How does that work in getting that care and that service for those kids?
So as we look at, for young children 0 to 5, as we look at identification and then special education services, that's going to be through their local school system. Many places have a really strong relationship where the private child care works very well with the local school system to look at the supports that they can have. Many of them send teachers within the community-based programs to support children and look at identification. It also, we serve children all over the state. There are places where that isn't as strong, and that is something that we're working with. I do think as we look at how we approach how we look at social emotional development, I think there'll be some ways that we can strengthen that. But it's also sometimes dependent on the relationship there at a local level too.
Okay. Thank you. Thank you, Madam Chair.
Any other questions or comments? Well, I want to thank y'all, because I'm well aware of the big steps you are taking, and they're bold, and we certainly need to support you in doing more of those. Back in the day when I got my degree in early childhood education, this was not a big topic. It really, really was not. And the reality of where our children are today and the needs that they have certainly changed. So I'm so grateful that Georgia has DECAL, certainly, and to be able to focus on that intense need. PBIS is just wonderful. I hope we will continue. I love the idea of taking that down, and after we do that, then we need to take it all the way back home. We need to present it in the hospital and help them see it right there, too. So thank y'all for the work you're doing. Thank you for this excellent information to help us. Next, we have from Voices for Georgia's Children, Erica Sitkoff. And Erica, I think you have a PowerPoint as well, I believe. So, thank you.
I'm impressed I figured that out so quickly. Well, first and foremost, a tremendous, huge thank you to Madam Chairman and the rest of the committee for shining light on this issue. Voices is incredibly appreciative of that. Myself personally, as a child psychologist, is incredibly appreciative of that. We are thankful for the opportunity to be here today and to get to be as helpful as we possibly can to you and your work to address this crisis that Georgia is facing. So thank you. You have heard a great deal over the last few weeks, including here today, from really brilliant colleagues of ours that are working in this area across a wide variety of needs. And so I didn't want to take too much time restating a lot of the statistics and evidence of the need that you've already heard, but wanted to more highlight some of those lessons and think about what can we do next to address this. As Representative Nix referenced the Get Georgia Reading campaign, we know that behavioral health and mental health lies at the core of children's ability to learn. You heard from Department of Juvenile Justice at the last hearing about how 70% of the children in the involvement with DJJ have mental and behavioral health challenges. We know that the language nutrition that you raised, that if young children and following DECAL, that if they don't have the skills that they need, their brains are not gonna develop as effectively. They don't have the communication skills. They're not gonna interact with their environments in the way that they need to be successful. And as Dr. Clark said earlier, that we know that especially for young children, psychotropic drugs should be the last resort, and often it's the first resort. So how can we, get to a place where Georgia can have every child graduate, can have them reading by third grade, are not using medication as a first resort, have the language skills they need to be successful, have stable homes. And we could not agree with you more, Representative Chandler, that a coordinated 3-year state child adolescent mental health plan is the way to get us there. But to figure out how to do that, at Voices, and I know we're not the only ones with this philosophy, we want to take a look at what is working, not only in other states, but what's working here in Georgia, because there's a lot of things that are working well here and pockets of excellence across the state. And that's where we wanted to start with you here today, and then use that to identify what's missing, because how are we going to figure out a solution for what's missing if we don't first look at what's working? And how do we use those two components to figure out that coordinated state plan? Because all those pieces feed into that. So we started out on this quest to build a snapshot of what behavioral health looks like from birth through adolescence here in Georgia across the state. And you'll have in your packets that snapshot. And we couldn't put everything on one map without driving, without it being too much. So we put it on two sides of the page. And I want to highlight a few things from there. One being that when we shared it with some of the folks here today in the audience, we learned it doesn't have everything on it, which I think is a positive, because it's getting that dialogue going of, let's think about what resources we do have. So we know, if we say we want more funding, well, for what and for where? Because there might be some resources that we're not sure that we have, or that one agency has but another doesn't. So a lot of what really has been even talked about today of coordinating systems, we want to see what those resources look like from a 30,000-foot view across the state. And what you'll see is that there are great pilots and programs happening pretty much within every agency across Georgia. You heard about Project Aware and the DOE with mental health first aid training and providing supports in the schools and providers in the community. Project Launch, the Department of Public Health, which really is the main work that's happening right now from birth to 3, in addition to the quality rating and work that DECAL is doing. But in terms of providing direct services and training providers, that's it right now as a pilot within one community in our state. We've got the Project Apex with DBHCD, which is working closely with the CSBs to infuse services in schools. We've got school-based health centers that are happening across the state. We have private-public partnerships where some school districts have taken it in their own hands and said, we don't have the number of staff we need in our schools, so we're going to work with our community providers and develop MOUs to get them to work closely with our schools. That's happening in some areas. So we've got some models that we can begin to look at what has been successful. PBIS that was just talked about is in every DJJ facility is using that successfully. We've got what's called peer support, youth and parent peer support, where you're looking at not a licensed provider, but a certified provider. So looking at different tiered and types of providers to try and help meet that need, because you've been hearing, about the shortage of licensed providers. So how can we look at other examples? And some of that's happening in our state right now effectively. And we've got some of that interagency collaboration happening. We've got what's called the IDT, the Interagency Directors Team, where you've got the directors at the different state agencies that oversee behavioral health. They come together once a month. It's pretty amazing. They meet for almost an entire day and talk about how to coordinate systems and strategy, as well as advocates and providers are in the room. We've got, the Behavioral Health Coordinating Council. We've got some of this collaboration, but it doesn't always, as we know, translate down. And so now I'm going to talk about some of what all that means in terms of what's missing. The programs that I mentioned, those pilots, Project Apex, Project Aware, those are all grant funded, which means, and I'm just talking right now. There's no slide other than the mat. They're going to go away. Some of which are going to go away next year. We haven't created a sustainable funding mechanism to meet the need. Some of that answer might be Medicaid. There might be other answers as well. But right now, we figure out a program that works really well, and then it goes away. So that's part of the challenge too. Also, where the funding comes from. If we've got different agencies, all of which that play a role of implementing behavioral health with children, and they get funding, how do you figure out how to braid and blend that funding so that as children cross systems, or even quite frankly cross boundaries, we know that the different agencies have different service boundaries and jurisdictions. So looking at some of that to figure out how we do that coordinating is going to be key. We know that regulations change, rules change, our Medicaid state plans change, or there's a mandate, for particular training, but maybe there isn't funding behind that, or maybe it's for one type of provider, but we learn, wow, like you were saying, wouldn't it be great if the hospitals also had some PBIS? So figuring out when we know something works well with one type of provider or one type of setting, like K-12, looking at how we can do that then in early childhood and care settings or in hospital settings. And really, and now I will go to the next slide, how we get there is through that coordinated plan, where ideally we would like to see it's a 3-year plan, because we know, first year implementation, they're going to hit bumps in the road, and second year you start to figure out what's working well, third year you really hone it, and then you're ready to tweak it moving forward. So we do think a comprehensive 3-year plan would be most effective, that has multiple stakeholders, representatives from agencies, the legislature, providers, advocates, parents, that really is a comprehensive group that comes together to provide input. That we take a look at what's working. So we'll be having, Voices will be having a lot of conversations after this, using that map as a good dialogue starter for, are there things that are missing here? Or are there things that worked that we thought were still in place but that have now gone away because funding has disappeared? And then to look at that gap analysis of where there are pockets that are missing. And figuring out that fiscal sustainability model is going to be critical, and oversight and coordination, the roles of the different agencies and how they can work together across jurisdiction lines, across funding streams is going to be incredibly important, and expanding what we know is working. And whether that's a funding issue and that's why it hasn't been expanded, or simply just figuring out the logistics of how to get a training module that we know works well in the hands of other organizations or other training teams within different agencies. And maybe it's just simply sharing of that information, that it doesn't need necessarily any additional funding. So we think that plan is how we're going to get there. And that's really our main recommendation for the committee. We'd love to see that come out in your recommendations. So thank you.
Thank you, and thank you for the work that Voices is always engaged in. I'll tell you, I reached down in my iPad case, and I pulled out my Get Georgia Reading, where PBIS was first introduced to me as well. You know, there are so many good things that Georgia is doing, and I think it's important for us to embrace those and to make sure that those are throughout our state, being implemented with fidelity throughout the state. So let's see if we have some questions here. I think Representative Gardner.
Thank you very much. And thank you for emphasizing the good things that are going on in our state. There's nothing that breeds more success than success, experience, making things work that are helpful for children. But because I know you know a lot more about PBIS than anybody in this room, I was hopeful that you would tell people just a bit about your background, particularly as it relates to PBIS.
Sure. Oh, my
work in D.C.
My personal background, absolutely. So before moving to Georgia, I led the health and mental health services for the school system in Washington, D.C., and that included implementing PBIS and those positive behavior supports across the district. And it was a tremendous effort to, well, one, you couldn't walk into a school and everybody from people that worked in the cafeteria to teachers to the principal that didn't identify behavior as a challenge and that didn't want to figure out how to be supportive of students and how to figure that out and maximize their learning. And training was incredibly important, not just about why behaviors occur, so there's some understanding and empathy, but then what are some concrete strategies of how to address them? But I'll tell you, in addition to prevention and having those universal approach, the social emotional curriculum and learning, that background is definitely important. Having a positive climate, everything from how you approach discipline to how you greet students in the hallway. Making sure that when all of those strategies don't necessarily produce the outcome that you're looking for, that you've got the resources you need at that tier 3 and tier 4 level to address the need. Because if you talk to psychologists and social workers and counselors, which I'm sure that you all do, in addition to already having very high caseloads, most of them, and I know I felt this way when I worked in schools, there's like 10% of the kids that take up 80% of your time, and it really doesn't allow you to get to some of that prevention work that you know can be so effective. And having those either private-public partnerships or teams within districts that can be deployed to give you that consultation or provide those direct services to students and families, that extra capacity that not every child needs, but again, that percentage of kids that take up the majority of your time was incredibly effective. And I mentioned some superintendents in Georgia are doing that now, where they're looking at how can they have those partnerships. I know it's a motivation of Project Apex as well with DBHCD and the CSBs of how can we take that expertise that's in some of our communities. Some of our communities, quite honestly, we know don't have that. There's just providers don't exist there, and that's something we have to address. But in communities that does exist, coming up with that private-public partnership model was very effective for us in DC, and then as well as seeing that here in Georgia and places.
And the superintendent was well-known?
Oh, in D.C., yes. It was Michelle Rhee, if you all have heard of her. So.
Thank you. Thank you for drawing that out, that fact. That's wonderful. That's very good. I'm so glad you're in Georgia.
I'm glad to be here as well.
Representative Chandler.
A quick question.
Yes.
Am I correctly hearing you say that one of the most appropriate things that we could do to help you is not pull funding when you find something that works?
Yes.
Okay, thank you.
Thank you for that clarity. We'll put that in the report. Okay. Are there any other questions or comments? You have something? Yeah, sure. Let me find your number. Representative Oliver.
Thank you for
Tweet.
this indulgence. Children who receive Medicaid, children who are entitled to IEP services, children who are entitled to EPSDT services have legal entitlements to adequate mental health medical care. And that's millions of children in Georgia, and that's hundreds of millions of dollars we're spending it. Why are they not getting the services that they're legally entitled to? Is it an enforcement issue from our perspective?
I think that's probably part of it. I mean, there are nearly half the children in our state receive their health care through Medicaid and Peach Care. That's a big number. There are a number of factors that play into that. One of them being what type of providers do we have in that community, and are those providers equipped to deliver the service that we need and to be reimbursed for those services. Being completely honest, providers need to be able to make a living as well, and if an LPC can't get reimbursed for a service, or the peer support model can't be reimbursed, they're not going to be able to work for free. So looking at what are the providers in the communities and what services can they be reimbursed for and what they're trained to be able to do as one of them. Looking at what that reimbursement rate is another. We've heard from providers that they've struggled to balance their caseload between, Medicaid patients versus private insurers versus out of pocket. Having a array of patients so that they can continue to keep their doors open. So that's something that we've heard.
My frustration is that we've spent additional several $100 million on the legal entitlements of adults in our mental health system based on enforcement from the federal government. That's affected a change, and we have not enforced the rights the children have. And I'm trying to put together in my mind all of these programs we're funding that children are entitled to that we're not enforcing.
I do think that that's some of it. I think having the data that you need to be able to address either specific providers or specific areas where it's not happening, I think that's always more effective. When you make a blanket statement that everybody needs to do this, you're always going to have providers that raise their hand and say, well, I am doing it, so they must not be talking to me. And having the transparency and the data that you need to be able to identify truly where it's not happening it always helps the reinforcement. Yes, having a case provides some reinforcement as well. I mean, that's evident.
Thank you.
And we agree that more needs to be done for children's mental behavioral services.
This gentleman, a pediatrician, who has a child before him who's Medicaid paid, child is entitled to services, that child has a legal entitlement to the services. How does that pediatrician, through a Amerigroup's contract, through a Medicaid enforcement, how does that pediatrician enforce that child's entitlement? That has always been a concern of mine.
Yeah. And I don't know the answer of how they do it, but I do think if we get every agency in the room, along with providers like Dr. Clark and other providers, to be able to put forth, here's what is happening, and what truly are the barriers to making that happen, including having contracts with the CMOs right in front of you. I mean, part of it is and I'll tell you, when we started to do this snapshot of what's happening across the state, it was challenging to find what really is happening, what accountability lies to whom. Those contracts are overseen by DCH, DBHCD has their role. Every agency has their role. And if you're trying to follow the money or follow the accountability, it's confusing. It's confusing for us. It is. I know it's confusing for families. And we've all expressed our frustration. So I think having truly everyone in the room and sitting down and looking at the full scope of all of this and identifying what are all those pieces, contracts, are what is allowable under Medicaid, what are our licensing requirements and training requirements for providers? Is there room there, like was raised earlier about allowing for continuing education units for language nutrition? I mean, looking at all those different pieces is going to be critical to answer that question of how do we then follow that line of accountability, and truly what are they accountable for? What does the contract say? What are our expectations?
Very good. Anything else from members of the committee? Well, if not, thank you so much. I know you couldn't see them, but behind you, heads were shaking.
Oh, good.
And my husband always says, that's not right.
Fantastic.
They're not shaking, they're nodding, Katie. So heads were agreeing, yes.
Wonderful. I'm glad to hear that. And we provided some handouts, and more are forthcoming. We're working on a Medicaid handout, so we'll continue to get those out to you. And we'll be updating our snapshot as we got great information today of more programs that are happening. So we'll continue to update that as we learn more. And look forward to being of help to you. Also, there's a green folder that was provided to you of other recommendations that are aligned with ours from other stakeholders that we encourage you to look at as well. And then there's another handout in there around telemedicine, and there's a lot of talk about that, and Voices has been working on that issue as well. And really all that is that process map of what it looks like from identifying a need to getting the service, so we can begin to, again, look at where is it working well, where is there challenges, where is it most effective versus maybe not. And anything as you look through those materials that you think would be helpful to know, please let us know so that we can continue to get materials to you that will be helpful in this work.
Thank you so much.
Thank
you are
you.
helping us, but you are really helping Georgia's children and families, so thank you. So next, as we move along, Gwen Skinner is here. And Gwen, you're the executive director at Devereaux, and not everyone may know exactly what Devereaux is, so why don't you start off telling us a little bit. Y'all introduce yourselves to us and tell us a little bit of background.
Madam Chair, thank you, and committee members for the opportunity to speak with you briefly today. And I will tell you about Devereaux, but I'll tell you first that I'm a former Deputy Commissioner of the Department of Juvenile Justice and a former Director of the Division of Mental Health, Developmental Disabilities, and Addictive Diseases. Currently, I am the Executive Director of Devereaux, Georgia Treatment Network, and I also chair the Georgia Alliance of Therapeutic Services for Children and Families. You may have heard it referred to as GATS. It's one of the major advocacy groups for children, provider advocacy groups for children. Devereaux is one of the largest networks of children's behavioral health care services in the country. Georgia's fortunate that they have a presence here. We have about 50 children who are in foster care. We also run a community-based group home, and then we run a specialized group home on the grounds of our campus where our psychiatric residential treatment facility is located. So we have a range of services. We have contracts with Department of Family and Children Services and Department of Juvenile Justice. About 65% of our children that we serve are children from Georgia, and then the remainder of those come to us because of the nature of the services that we provide, very specialized services, come to us from as far as California Department of Education sends children here, Washington, D.C. sends children here. We've had children from the Virgin Islands, so all over the country they come here. I think you may have heard Dr. Yolanda Graham speak before on children's issues, and she is our medical director at our facility, so they come for access to Dr. Graham also. You, Representative Dempsey, had the opportunity to come and meet with the GATS membership along with Roma Amin, who we had a great conversation regarding the strengths and the weaknesses of the mental health system and the role of the providers, because the providers want to partner. But it's not always easy to partner because of the complexity of the problems in our children's behavioral health system. And I think the invitation today was an outgrowth of that meeting. One of the good things about being one of the last to present to you is that the groundwork has already been laid. You've heard from most of the major players. They've explained their roles in the mental health system. They've provided you the data. They've presented on some of the major issues, such as gaps in the Medicaid coverage, lack of providers in rural areas, lack of a cohesive, accessible system of evidence-based services and treatment, regardless of what the payer source is. And I think that the very existence of this committee is an acknowledgement that the system isn't working as well as we would like to see it operate. This is particularly true for Georgia's uninsured population of children. And evidence of that is everywhere. We know that the children are not screened for behavioral health problems, and when they are, treatment doesn't follow. I've been in the children's service delivery system for more years than I'm willing to say, and that part has not changed. We've known that we do a good bit of screening on certain topics, but the treatment doesn't follow. There's an inadequate array of services, and the current array is largely based on adult models like individual counseling. That's not the best model for a 4-year-old. When more than one service is needed and 2 services are delivered on the same day, only one service is billable. This remains true even when it may be more convenient for the family to have multiple services on the same day. They don't get a choice in that matter. So they have people coming and going in and out of their homes. The Georgia Network of Therapeutic and Educational Support is cited for segregating children with mental health and behavioral health needs, which is undermining the ability of the child and the family to access services. Our psychiatric residential treatment facilities for children are full. And I recently met with the Council of Juvenile Court Judges about why, when a child goes into treatment, do they only stay for a short time and then they're back. And I would tell you that part of that is because the system that we have in place today is driven more by behavior than by the clinical needs of a child. When it rises to the level of a hospital level of treatment and a child comes in because of serious behavioral issues, we have to justify them being in treatment. Usually every 7 to 10 days we're having that conversation about why they're here. If they do not display the same behavior that was a concern in those 7 to 10 days, then you can't justify the treatment and they're back out in the community again. So it's very behaviorally driven. When children are able, when they're completing care and they're going to transition from inpatient care to outpatient, the current practice models don't adequately address this. And the same could be said for children transitioning from child and adolescent services to adult service. It's when children are transitioning that they need more services and they need the less transitional support services, like behavior aids at school. Much of the data that's been presented is siloed because it's specific to a particular agency and it's their perspective, but at the end of the day, the only thing that really matters is that children are being screened appropriately and receiving the necessary services. And to that end, as your committee is considering all of the information that's been provided and formulating your recommendations for the next steps, I'd like to make some suggestions about the data that you might consider. And this is relatively simplistic. I would think that you would want to look at, from DCH, the total number of children receiving health care from the Georgia Families Care Management Organizations, including Georgia Families 360. Of those children, what percentage had an age-appropriate behavioral health screening as part of their early and periodic screening, diagnostic, and treatment health check appointment? And of those, what percentage were referred for appropriate treatment with a behavioral health provider? We also recommend randomly selecting a few actual children who were screened and see what happened. A comparison of the length of stay for children receiving treatment in a psychiatric residential treatment facility under the system managed by the CMOs under contract with DCH compared to the length of stay previously authorized by APS under contract with the Department of Behavioral Health. Is it any different now than when it was being managed by the Department of Behavioral Health? It is a fact that there are about 144 children who are currently receiving treatment in the psychiatric residential treatment facilities. And we know that about 19% of these are paid for with state funds because CMOs have determined that they do not meet the criteria for a hospital level of care. The challenge with that is their behavior is such that no lower level of care provider will accept them. So they're in the psychiatric residential treatment facilities using state dollars. So if you look at a comparison of the services authorized by DCH, contracted CMOs, and those authorized by DBHDD, contracted APS, you can compare. You can also pull the data from DFACS, DJJ, DOE, and DBHDD and say, are we spending more state dollars now because the services are not being covered by the CMOs? And I think that's very telling, because we have had children who have been in psychiatric residential treatment facilities for years waiting for a placement. Years waiting for a placement. We believe that the consideration of this data will provide information that's critical to understanding the impact of the changes to the children's behavioral health system over the last several years and the current status of the system. And that the data is critical, but there are additional steps that could be taken as we work to improve the system. And so from a provider perspective, we would like to see the committee recommend that representatives from the 4 major provider organizations, that would be GATS, Together Georgia, FFTA, and the emergency shelters, be incorporated into any work to improve the system. We're often asked to speak, but too often are not at the table as a working member, and it's because of the assumption that the providers are somehow making money off of the children receiving treatment, and so it would be a conflict of interest for them to be at the table helping drive the decisions about the improvements of the system. The truth is the provider organizations know which providers have expertise in particular areas that need to be addressed. Having worked in 2 different child serving agencies and now as a provider, I can tell you, as an agency director, because it was true when I was there, we don't always listen closely enough when providers attempt to explain what we're doing that keeps them from giving us the services that we want for Georgia's children. And this is due in part, it's legitimate, this is due in part because if you are operating a state agency, you're dealing with volume. And so they are caught up in dealing with a large number of people. Case in point, we know there is insufficient capacity in the foster care system and other residential services. We know that. We know that's why children in some instances are in hotels with case managers. We know why they're in the PRTFs and they can't go somewhere else. We know this. To the credit of DFACS, they have come to the table to work on this issue, and part of what we have found when we talk with them about rates is that providers are paid roughly, and DFACS will tell you this, about 75% of their cost to provide the service. So when we go out and do fundraising as nonprofits, we have to be geared towards raising that 25% to keep the lights on and the doors open. So we have no funds to increase capacity. Increased capacity is needed to meet the demands of the agency, but because our funds are tied up in the operations, we can't respond to the agencies. So something has to change. No provider can create more capacity with the expectation of a greater financial loss and an unstable business model. I think telemedicine holds huge potential for Georgia, and I think you have providers who have psychiatrists on staff, who have clinicians on staff. We could use telemedicine, but again, we're busy out raising the 25% of the funds that were not paid to keep the facility open. Georgia's fortunate because we do have several providers that have strong financial support, like Devereaux. Our state can't afford to lose them. Every time I hear the rumblings of we're about to lose one, it makes me nervous because I know they do question how long they can afford to do business at a loss. And some of the larger, deeper end providers want to restructure to meet the needs of the state agencies, but we're unable to do so because we're too busy raising the money. Remember the 144 children that are in the psychiatric treatment facilities and the 19% that are covered by state dollars. That's probably, somewhere between $9,000 or $10,000 a day that's being spent in state dollars at least on behalf of those children. And I wonder what would happen if we were able to use that money to develop the step-down programs and best practices they need. We wondered the same thing when I was with juvenile justice, how to run the institutions and develop the alternative to detention programs needed to keep children from further penetrating the system. And the challenges aren't new, and they certainly aren't unique to any one agency. The state-operated mental health hospitals have the same challenge as they work to transition consumers from the hospitals to community-based living arrangements. I contend that the providers, the actual providers of the services, the people we expect to respond to the demands and needs of the state agencies have to be at the working table if we have any hope of changing the service delivery system. You know, I was thrilled when I looked at the makeup of this study committee, and we are so thankful for your time and your dedication to children's issues, because we know that children are not the committees that your stronger committees in terms of legislators running to be on these. It's very complex, and you have to be very dedicated to the issue. We're hopeful that you'll secure and study the data that we've suggested and consider our recommendations. Make screening for behavioral health and the provision of treatment the required routine, and I agree, it is their legal right, and we should figure it out. It cannot be that difficult. We should create an adequate array of services using models developed for children and adolescents and not continue to use adult models. That we allow multiple services to be delivered in the same day, that we provide for enhanced support services during transition times, because that's when we lose children, that we involve the 4 provider organizations in a meaningful way as plans are developed, and support paying providers the cost of delivering treatment services. And I think you'll find out the providers will come to the table every time, and they will open their doors to you so that you can see I do think that we're doing very good work in some areas in Georgia, and we would love to have you, any of us would, to visit our facilities. Thank you.
Thank you so much. Are there any questions or comments from the committee members?
We sit here with our mouths hanging open. Thank you very much for your very astute and straightforward presentation. I don't seem to have a copy of it.
I've got one for you.
Okay. And you sort of play into the Voices idea of having a 3-year strategic plan, hopefully with the whole range of providers, not just the ones who happen to have contracts right now, to help figure out how to do the integration that we know is needed and meet our legal obligations through the EPSDT. So
it will take the providers, because they understand the experiences of the children. They understand how you work with the state agencies. They have to be at the table.
And the problem is we're trying to keep children out of your institutions. I mean, that is our real goal, is to put you out of business. But so far we're not doing so well.
And we have that conversation often about, because of having to constantly fundraise, what you have in Georgia are historical, in some instances very large providers that can change their book of business. Just because you started off as a psychiatric residential treatment facility, that's just buildings. That's why you see some providers like Devereaux do foster care, do group homes, do other services. And we're very clear, the future is not in running psychiatric deep-end facilities if we do what we're legally bound to do with EPSDT. But what is absolutely key is that we've got to identify the children. And so it does start. I agree with everybody I've heard speak today. It starts very early. It won't be answered in the juvenile detention centers or in the state mental health facilities. It's about EPSDT.
I was particularly alarmed about the state dollars that we use that actually could be used to match federal dollars that are available if we would figure out how to do it with children. Mm-hmm. Without changing or expanding anything. Thank you.
Thank you.
Nice to have somebody with that kind of history.
Are there any other comments or questions from the members or our 2 guests that are with us at all? You did an excellent job. You told us real straightforward, so I'm sure we're all just trying to process it. And if we do you have that document, what you've just shared with us?
I have it to leave.
Great. Leave it with us and let us make sure that everyone on the committee has it to look at and to really look at and reflect upon again, because that is a lot, without a doubt, to take in. And your history, your engagement in addressing this problem is very well respected. So I thank you.
Thank you.
Yeah. Gwen, tell everybody where Devereaux is. They just that came up here. Can you just?
Devereaux, the campus.
Right.
Proper is in Kennesaw.
Mm-hmm. Great. Okay, our next speakers, we have a group, and I don't think y'all have a PowerPoint, so you may want to sit. You do have a PowerPoint? Okay, well, great. Well, let's just move back and forth between the table and the podium, however you need to. Rabin, Garrett, Gano with she's the director of the Georgia Association of Community Service Boards, and Heather Stanley, CME Director for Lookout Mountain Community Services, and Cindy Levi, am I saying that right? Levi, CEO of VITA Community Partners. Y'all feel free to sit or stand or be wherever you are comfortable. Thank you.
Madam Chair, thank you so much for this opportunity. As Director of the CSB Association, I want to extend a big thank you from across the whole state. We do represent the 26 community service boards. In addition to Fulton County Mental Health, is that better now?
That's better. It's my fault.
Usually I can yell. I don't usually talk too
No.
soft. So in representing the 26 community service boards as well as Fulton County Behavioral Health System, we are indebted to the leadership that you have here on the study committee. And Representative Nix, thank you. As a resident of Carroll County, it's really important to know that you are here and that you care about the children in our communities, as well as your leadership here that shows your compassion for our kids across the state, our children and youth. So I'm here to introduce Heather Stanley, who is the director. She's a licensed therapist, and she is the director of a specialized program that I'm not sure, I don't think that you guys have had an opportunity to be educated on this process and how it relates to the service delivery system in Georgia for our children and youth. But we have such a thing known as the care management entity. And there are 2 of those across the state that provide statewide services. And Heather Stanley is the director of one of them, which is provided and operated by Lookout Mountain Community Services, which is our community service board in the northwest corner of Georgia. We also have Cindy Levi with us, who is the CEO for VITA Community Partners, and she is going to be able to talk a little bit more about the comprehensive service array that the community service boards have the capability of providing that the payers accept what we provide and authorize those services. And I say that and put that little plug in because I've heard some questions from the membership of the study committee and some comments from our community partners who have presented today with regards to that. And this goes back to Representative Aller's comment earlier too. So she'll be able to talk about that comprehensive service array as well as the specialty clubhouses that she provides that are also located across the state. Not near enough of them. But thank you again for the opportunity, and we're happy to provide any additional information afterwards.
Good morning. I'm Heather Stanley. I'm with Lookout Mountain Care Management Entity. As Robin said, there are 2 in the state. The other care management entity is Viewpoint Health, and Chad is my counterpart, and along with his deputy director, Cordelia Callan. So Lookout Mountain, Viewpoint Health, care management entities, our main focus is to provide wraparound, which is a promising practice. It's not evidence-based just yet, but that's because they haven't quite figured out how to fit a round peg into a square hole. So it is a promising practice. There are fidelity measures and a lot of expectations that have to be met to prove that a youth is receiving quality services. Our main focus is to encourage youth to use a strength-based approach. We work with the whole family, not just the identified patient. But we also connect them back to community resources. So we help them stay in their community, stay with their families, and then also connect to the resources that are available to them in their areas. Some of the things that we've experienced as barriers to coordinating care has been when you're in a rural community or a resource poor community, it's hard to coordinate things that aren't available. So helping families find other resources, helping families find other ways to meet those needs when there's not a resource there to link them to that's directly related to their community. One of the other barriers that we struggle with is how to help families be connected and receive access when those services aren't authorized. Our struggle is we know what's needed and we know what families want and what they see would be useful, but they're not able to access it because it's either not available or it's not authorized. Because what we find is that people want to authorize services for in clinic, but families don't have transportation to get there, or they don't have access to get there, or they can't get there because of their work schedule, or because they can't miss any more work because they're going to get fired because they've missed so many days up to this point because they've been managing behaviors. So what we experience is, to help them find better ways to meet their needs in their communities, we have to be outside the box. So we really look at, what can we do in your community? If it's not mental health, then what's an alternative? So we refer them out to alternative therapies, equine, art, dance, music. One of the barriers there is that most of those are not Medicaid billable, so then we end up having to identify flexible spending dollars to help fund those, make access available. Criteria. So we work with kids from ages 6 to 21. They're the high-end utilizers of service. Most of the kids that end up in a care management entity have multiple systems, multiple involvement. They've got DJJ, they've been involved with DFACS, they've been to a PRTF or a CSU in the last 90 days. They have had multiple community services that have either not been successful or they've escalated to the point where they need higher intensity. Also, we work with kids that are uninsured or Medicaid eligible, and then we help address all of those needs from a strength-based approach. Usually, youth that meet criteria for a CME have already been to a PRTF or a crisis stabilization unit at least once within the last 90 days, and usually we see that it's happened multiple times. The other criteria is that they have to have a mental health diagnosis. It can be co-occurring with substance abuse or developmental disabilities, but the primary has to be mental health. So I've talked about some of our barriers. I've talked about our criteria. The major pieces that we want to be sure that we share with you is that we cover the entire state, all 159 counties. Both CMEs are available in any county across the state. Most of the time, we actually have boots on the ground in a neighboring county, if not the exact county that the referral's coming from. We have partnerships with AmeriGroup 360. We get our funding through Department of Behavioral Health and Developmental Disabilities. And we have several different funding streams that are available to us through Department of Behavioral Health. That's about it.
Talk about your family navigator.
Oh, okay. So we also have partnerships with certified peer specialists that are parents. And they, so we have some, Lookout Mountain has some that are in-house that we hired. They have lived experience. The expectation is that they walk alongside the parents and help provide different perspective from where they, the parent themselves have been through these systems. They understand what it means to have a child with special needs and need that extra level of support. And then we also contract with family support organizations to provide that same service through contracted. So their main role is to go to work with the parent to help them understand. There's now a statewide certification program for them, and they are going to be added into the state amendment so that they can also bill for those services. Anything else?
It's a question.
So you're part of the CSB Association. This is really interesting and important. I mean, this is where the money gets saved, right?
Correct.
By treating the people who are the frequent flyers, so to speak.
Absolutely.
What's the relationship with the CSBs?
So we are contracted through DBHDD. However, my employer, my umbrella, is Lookout Mountain Community Services. Same with Viewpoint Health. So we are a CSB. It's just a separate program.
So you're contracted with 2 CSBs.
The CMEs are contracted from DBHDD, but it runs through the CSB. Viewpoint Health, Lookout Mountain Community Services.
So there are 1 million people in Fulton County that I represent. So how does that impact on our county, since we really don't have a CSB?
The CMEs provide coverage to every county in the state. So Fulton County probably has, I would say, upwards of 4, maybe 6 actual CME staff available at any time.
Really?
Yes, ma'am.
And how do I reach them?
I can give you my contact information, and that would be the quickest way. But we both have websites that tell you how to make referrals. We have referral specialists that help walk families through the process. Make community partners make referrals all the time.
So GCAL, the referral service.
I don't think we're connected to GCAL.
And there's a brochure that we also provided.
But GCAL is the referral service for the state, right?
Yes, for crisis.
Created by Commissioner Skinner, I think it was. But anyway, glad to know that that's beginning. It sounds really important to me.
We've been in existence for 9 years. So we had a SAMHSA grant, and then we evolved into fully sustained state funding.
Fabulous.
So we've been doing it for a while.
Are you calculating how much money you're saving?
Yes and no. So we have statistical information that shows from the beginning, which was 2009, up to 2012-13, but we've not been able to get the cost study since then. So they're working on it.
As one of our earlier presenters mentioning, sometimes we don't know the good things that are going on.
Right.
Representative Chandler?
You mentioned parents not being able to take off from work to be able to obtain the services that they need. And I know you have nothing to do with the schedule of those to whom you refer these parents. But does your staff work on a flexible day so
Absolutely.
that parents can come in the evening?
Absolutely. One of our guiding principles is that it's family voice and choice. So what we do is sit down with the family and say, here's my calendar. I'm typically in your area on Monday, Tuesday. What time works best for you?
Okay. Thank you.
There aren't any other questions or comments at this time, but there might be some
Sure.
after. So let's see if we go into the next presentation.
Okay, I had my presentation up here, but I don't know what happened to it. It disappeared.
Well, we will
So I
get,
may have to just bring it back up quickly. Because it has a lot of pictures, so pictures are better than the words.
okay, well, we'll give you time for that.
Thank you.
And we can definitely make it available and attach it later if there's any.
We'll send it to you.
That'd be great.
To run electronically.
That'd be great. That'd be great. We'll add it. While you're doing that, I want everyone to know, the committee as well as everyone who's here, that I happened to look last night online, and there is an excellent body of work to look at from what we have done through these meetings. So I encourage you to go back and revisit it. We have undoubtedly taken in a lot of information, but it is there, and I hope you will take time and review and refresh it. It's on the House website. It says Study Committees. You click on that, and then all the names come up, and there are a lot of them this year, but we're there. So it will list each of our meetings, and I believe each and everyone up to this point had a very, very good documentation, I would say.
Okay, thank you.
Great.
Sorry that it took an extra minute. Good morning, and thank you very much for the opportunity to be heard. I'd like to provide you with some follow-up to Matt Yancey's presentation to you on September 10th. At that time, Matt introduced you to some of the unique services provided to children and families through DBHDD funding by the state safety net providers. I'm going to make his presentation personal by adding faces and places to the services that he described. To put this in perspective, VITA's geographical catchment area encompasses the 13 counties of northeast Georgia. The two most populous counties in these areas are Hall and Forsyth County, home of the city of Gainesville and one of Georgia's fastest growing cities, Cumming. As you move further north, you enter very mountainous and rural areas. Oops, let's go the other way. So let's start by taking a trip up north to Rabin County, a rural county with a population of only 16,000. This is the home of one of Georgia's 6 resiliency support clubhouses, named Fort Dreaming Tiger by the clubhouse participants ages 7 to 14. Named that because the program helps these young people develop the skills to reach their dreams in Tiger, Georgia. In addition to the 6 existing resiliency support clubhouses, grants have been awarded to start 6 more across the state. The clubhouse resembles a cabin, a serene environment to promote learning and growth. As you can see, the following outcomes are set to measure the success of these clubhouses. Things like increased mental health functioning, decreased Department of Juvenile Justice involvement, increased youth engagement, increased family engagement, increased peer support skills, and increased home stability. All things that are supportive of healthy families. All 31 children served over the past fiscal year improved their functioning levels as measured by their Child and Adolescent Functional Assessment Score, or CAFAS score. They were referred to us having difficulty in school, with most failing at least one class, oftentimes more than one class. I'm very proud to share that 100% passed all of their classes last year and moved on to the next level. No out-of-home placements occurred, no legal involvement, and families participated in both on-site and off-site activities, exactly what we want for healthy families. Children learn through hands-on and interactive opportunities. Here's an example of a way that youth build trust, team building, and build confidence while participating in zip lining and a ropes course. Next, let's move on to Hall County, where community service providers join with the court system in a variety of accountability courts. One example is a family treatment court. This program has been operating for 9 years and is based on the belief that addiction is a chronic and potentially fatal disease, creating one of the most serious health and legal problems in the United States today. Family Treatment Court works intensively to prevent unnecessary foster care placement of children and expedited return to a safe, stable, drug-free home for those children who are in foster care. Participants receive group and individual counseling services. That's both for the adults, the parents, and the children. They have random drug screens, are taught how to develop and taught how to develop healthy family relationships. The evidence-based practices and promising practices utilized include moral recognition therapy, celebrating families, strengthening families, motivational interviewing, and rational emotive behavioral therapy, all proven practices. Every Thursday, participants gather together for a family meal. That's all of the participants, and upwards of 60 people at one time. And that meal is prepared by one of the participants. For decades, the family table has been the place where families gather together, break bread, and communicate with one another. Unfortunately, families that are broken do not do that. So this is a practice that we encourage. Next, let's travel to Habersham County. Here I'd like to demonstrate the philosophy of the Dream Weavers, a group of self-advocates with developmental disabilities that believe in people helping people. Their mission is to give back to their community. One way they live their mission is through the 100 Monster Project. The individuals with developmental disabilities made stuffed monsters out of scrap fabric. They invited high school students to work with them to individually name each one of the little monsters. Then in a special ceremony, all the Dreamweavers hugged each of the monsters, then gave them to the DFACS workers to distribute to displaced children, to comfort them during a vulnerable time when they're being removed from an unsafe environment. Children are easily distracted and oftentimes not interested in sitting down to participate in talk therapy. By making the space fun for kids, they open up and share their inner feelings. Sitting under this big tree gives them comfort in a safe environment. Youth were engaged as part of treatment to use their artistic talents to make our play therapy room kid-friendly. Georgia has a shortage of psychiatrists, and board-certified child and adolescent psychiatrists come at an absolute premium. In an effort to make these services, specialized services, available across a large geographic area, we utilize technology to bring this service to the youth and their families through telemed. This is a great way to maximize efficiency and use of a very scarce commodity. The Department of Behavioral Health and Developmental Disabilities does hold all of the community service boards to a standard, a key performance indicator of having any individual that seeks treatment see a psychiatrist within 14 days of request. We're very proud of the fact that we're meeting that standard even with a scarce commodity. At Avita, we do have 3 board-certified child and adolescent psychiatrists and advanced practice registered nurses with specialized training in child services. So they get top-notch care. System of care grants have been made available to organizations interested in supporting children and families outside of the traditional clinic-based services. There have been 14 organizations awarded up to $100,000 each, and they were able to present their own ways of addressing these issues. A few examples are things such as the Right to End Bullying Project, addressing an ever challenging problem of bullying within our schools. Also offering suicide prevention workshops, as that is another concern of our young folks. Offering a child trauma conference for other practitioners and providers to learn about how to deal with trauma. The provision of play therapy equipment and play therapy training. The purchase of some African drums. Participation in community activities such as Partnership for Protecting Children and the Child Death Review Team. Here's an example of utilizing the African drum in a way of developing the roles of leadership and teamwork, while of course expending some of that childhood penned-up energy. DBHDD has embarked on the APEX project this fiscal year. This is a grant-based funding opportunity to take services to where the children are, in schools. Schools are selected based on Title I status, attendance data, and school climate star rating. In our area, we are able to provide these services in 5 of our schools. And it includes treatment, prevention activities, and support groups. Another youth-serving program is through substance abuse recovery support clubhouses, like this one in Gainesville. An evidence-based practice called the 7 Challenges is utilized in this environment. 9 of these clubhouses across the state focus on the following outcomes: decreasing substance use, decreasing Department of Juvenile Justice involvement, decreasing behavior problems, increasing positive social function, increasing school attendance, improving family involvement and relationships, and the target population is 13 to 17-year-olds. These goals are met by engaging the adolescents that are in middle and high school in meaningful and purpose-filled activities, like this example, receiving instruction from an arborist and volunteering to plant trees in a local park. These activities teach adolescents how to be contributing members of their community and how to participate in positive activities, making good choices to stay away from drugs and gangs. As many of these adolescents come from broken homes with a history of drug use and criminal activities, we teach them valuable life lessons and include their families to learn healthy ways to support their children. This particular example was when they were preparing a family meal with consultation of a dietitian and a chef. One last opportunity I'd like to highlight is the Emerging Adult Support Services. DBHDD issued 10 grants to develop unique ways to engage young adults during a time when most individuals experience their first psychotic episode or their first bout of depression between the ages of 16 to 26. So the goals of this program are to bring education regarding mental illness to high schools and colleges, support emergency housing for transitional adults, assist transitional adults to obtain employment so they can be independent, and assist with GED preparation for those who have not completed high school. I hope this gave you a better understanding of what is being offered in the form of prevention and treatment of mental illness among our youth. Many of these services and programs were started recently with the influx of funding through the DOJ settlement. Our hope is that the legislation will see the value of these services and programs and not only continue to support them, but to increase funding for mental health services. The children of today will determine the future of Georgia. Thanks for your support.
Thank you so much.
You're welcome.
Okay, are there any questions or comments for Cindy or for Heather? Yes, Representative Chandler.
My comment is that's fascinating to see that that's going on. Thank you.
You're very welcome. And I have to say that oftentimes when I'm addressing the staff in my organization and acknowledging them for the work that they do, they say that's a proud mama moment for Cindy. And I have to say that having the opportunity to present these wonderful programs to you today is a proud mama moment for me.
Representative Gardner.
I heard you say that you served 5 schools. How many schools are in this region that they have assigned to you?
Well, what happened with the Apex project is we were to present a specific area that we wanted to cover. And so our project is in Hall County. So we are primarily covering Hall County schools and Banks County schools. And with a funding of $100,000, until we actually hire 5 therapists to work, that's eaten up very quickly.
Yeah, no,
So I think part of what I want to get across today is that, you know, what I presented to you today was kind of a snapshot, and it's some great things that are in little pockets across the state of Georgia. There are pockets of excellence, and my recommendation is that all residents of Georgia have the opportunity to take advantage of these types of programs.
So you know the need is great.
Thank you.
Thank you for what you do.
Thank you.
Thank you. Those are very important pockets of excellence, too. I'll tell you that. You should be a proud mama, a proud administrator and leader. I really appreciate you sharing those examples that, as you say, do take what Matt talked to us about at our very first meeting and now put some life, some fact, some reality into them. So thank you so very much.
You're welcome. Thank you.
Thank you. So this brings us, well, let me ask first off, is there anybody else that's here that needs to share anything with us? Anything else you've thought of or feel like we need to know about at this point? Great. Well, I know we've only barely begun. I know that. I know there's well, it's kind of foolish for me to ask that because I know each of you could come up and talk and talk and talk and talk. We could go through a lot. This is a very big challenge that we're facing, but I am grateful to say that I feel like the committee has been presented really a robust body of information. We've heard a lot. We've asked a lot of very good questions, so I thank you for that, and I hope that, as has been encouraged by each of our speakers, that if there are more questions that you have, that you reach out either individually or through me or through Roma. And the same thing for each of you if there are questions that you have of us. We face now a profoundly important opportunity, I think, to put together a document that pulls all of this together and is open-ended enough to allow for all kinds of opportunity as we put it forward. And I will tell you, I've had the privilege of doing some other work on study committees where it is a very good feeling to go back and to pull this up and be able to say, well, as mentioned in, as stated in, as encouraged and demanded that we really should try to do is in some of those previous documents. So that will be our goal. And Roma will be taking the lead on it. She's put together some wonderful information. I'm so pleased. I cannot thank you enough, Roma, for the presenters that you have invited and put forward and the information that you've given us to build this conversation on. It will be a long conversation, there's no doubt. Many of you have been here working on this all of your lives. I recognize and appreciate that, and I'm so grateful for that work. We will continue from here. I would say to the study committee, if there are thoughts that you have that are profoundly important, that you really feel need to be stressed in this, feel free to call or to put it in writing. Get it to me, get it to Roma. Talk amongst yourselves. Let us put together something that is really good and really affects the future for the children of Georgia, all children of Georgia, but particularly those who are touched by the challenges of mental health. If there is nothing else, we are officially adjourned, and I just cannot thank y'all enough. Oh, whoop, Pat. Representative Gardner.
I just want to thank our chairwoman.
Oh, thank you.
For doing such an excellent job of providing a wonderful array of speakers so that we all can expand whatever knowledge we have and hopefully make a difference starting in January. But thank you very much for your work.
Oh, well, it was a privilege, and I do think we will make that difference together. Thank you.